actually the only disclosure that I have, and this is a little bit of a tangent, is that I'm a huge golf nut. And just recently I had this ultimate secret wish come true. So I got really excited, so I wanted to share it with you all. So that's me. That's Michelle Lee. And that's Christina Kim, her BFF. And these are, for those of you who aren't into golf, these are two stars on the Ladies Professional Tour. So no disrespect to Dr. Capasso, this was by far my greatest Stanford experience.
Where's your club?
They're on the putting green right next to the range. So it literally took me about an hour to work up the nerve to go over there and ask her for a photograph. So I turned into a 13-year-old girl. Yeah, she's about, I think, 6 feet. She's got a good 6 inches on me, I think. So, sorry. I could go on and on about this, but back to the real subject at hand. So I have no relevant financial disclosures. So just a outline of where I'll be going with my talk tonight. So first we'll just do a brief introduction into obstructive sleep apnea. And we'll do an overview of awake preoperative assessment tools. And the meat of the talk will be a focus on assessments done while the patient is asleep. Partial or complete collapse of the upper airway during sleep. And it's usually associated with an arousal or blood oxygen desaturation. And this can result in disrupted or fragmented sleep and varying degrees of hypercarbia and hypoxemia. So in this picture, we can see that the upper airway is essentially a non-rigid muscular tube that's prone to narrowing when we fall asleep. Typical choke point areas are the soft palate and the tongue base area. So sleep apnea is a common disease. It's estimated that 24% of men and 9% of women suffer from sleep apnea. And it does tend to worsen as we get older, so approximately 60% of adults over the age of 65 have at least mild obstructive sleep apnea. 1/3 of patients with sleep or disrupted sleep or snoring will seek out an otolaryngologist for evaluation and treatment. And a recent study showed that 92% of otolaryngologists are involved in the care of patients with sleep apnea. So it's easy to conclude that otolaryngologists are commonly involved in the care of patients with sleep-related issues. So what are the health consequences of sleep apnea? Patients suffer from daytime symptoms due to the fragmented sleep that occurs. And this can include excessive daytime sleepiness. There can be neurocognitive impairments, which can affect executive functioning, motor coordination, poor concentration, and memory. And sleep apneics often have a decreased quality of life, and they're at higher risk for depression, anxiety, irritability, and aggression. In addition, sleep apnea is associated with increased morbidity and mortality. So these patients are at higher risk of developing coronary artery disease, hypertension, arrhythmia, stroke, and even early death. So first-line therapy for sleep apnea are typically medical treatments, which include weight loss, oral appliance therapy, or continuous positive airway pressure, or CPAP. And surgery is typically reserved, at least in the adults, for patients who have failed CPAP. So when we evaluate the upper airway, we recognize 3 major zones of obstruction: the nasal region, the palatal region, and the tongue base region. And we obviously have a multitude of procedures that we can choose from. This is just a small sampling of those. So with all these surgical options to choose from, a common question is, well, which surgery should I perform? obstructive sites can help the surgeon design targeted and effective treatment for the patient, and ultimately, or hopefully, help predict and improve outcomes of these surgical procedures. So, in 1996, this was a big landmark paper, Scher did a meta-analysis, and this paper demonstrates why it's important to determine levels of obstruction. So in his meta-analysis, he found that 50% of patients who underwent an isolated uvulopalatal pharyngoplasty, or UPPP, were non-responders. He defined response being a 50% reduction in the AHI and an AHI less than 2. And in the paper, it suggests that maybe this poor response rate could be likely secondary to inadequate patient selection. And it also suggests that a good diagnostic workup to localize site or sites of obstruction could potentially achieve better surgical results. So if we're looking to improve our surgical results with our preoperative assessment, what tools do we have available for us? So we'll start with some quick ones first. So the physical exam is very important. It's nice because it's quick, it's easy, it's inexpensive. As otolaryngologists, it's something that we're obviously very facile at. The issues are that it's done while the patient is awake, and it's essentially just an anterior view of the oral pharynx. Back in the day, and still even now, people will use cephalograms, lateral cephalograms, and with this type of picture, you can assess sort of posterior airway size, palate length, and then it's still currently used to assess dentofacial relationships, particularly if you're doing MMA. The issues with this exam is it's a two-dimensional image, it's static, so there's no dynamic to it, and the patient is awake and upright. Three-dimensional cone beam CTs have been developed. This is nice because it gives you these pretty three-dimensional posterior airway dimensions. I always say they're very pretty to look at. But it has the same issues a cephalogram has. So it's patient's awake, patient's upright, it's totally static. So most surgeons will do an awake fiber optic exam as part of their clinical exam for their sleep apnea patients, and it's nice because you can visualize the retropalatal and the hypopharyngeal areas, so you're getting a better exam. Obviously, the patient is awake during this exam. I just want to add a quick word about the Mueller Maneuver. A lot of people will add a Mueller Maneuver as part of their fiber optic exam. And so a Mueller Maneuver, to quickly review, is you have the patient inhale via a closed mouth and nostril. And this creates negative pressure, which can cause upper airway collapse. There have been several studies that have looked at the predictive value of the Mueller Maneuver. These studies found that the Mueller Maneuver was useful, and the definition of useful was not exactly the same in all of these papers, and somewhat vague in some of them. And then 4 studies did not feel that the Mueller Maneuver was a predictor of surgical success. So overall, the results are somewhat equivocal about the Mueller Maneuver. And I think part of the issue with that is that the Mueller Maneuver is dependent on how much effort the patient is putting into that inhalation that you're asking them to make. So, for example, healthy subjects typically obstruct at closing pressures of -10 to -17 megabars, but during an awake Mueller Maneuver, these same patients can generate pressures up to -80 megabars without any signs of pharyngeal collapse. So, the Mueller Maneuver is probably not a reliable simulation of collapse during sleep, but it can certainly give, I think, the surgeon some idea of what and where potential areas of collapse occur. So what are the tools that can dynamically assess the upper airway under sleep conditions? Well, there are 2 major ones, and this is where I'll be focusing the remainder of this talk, and then also trying to present some evidence-based medicine about each of these tools. drug-induced sleep endoscopy, and the second will be sleep MRI. So to perform a drug-induced sleep endoscopy really is a team effort. Your friendly anesthesiologist will chemically induce a sleep-like state on your patient. At that time, you as a surgeon will endoscopically examine the entire pharynx from the velopharynx to the hypopharynx. Obviously, you'll be looking for sites of obstruction, and it's ideally a dynamic exam done while the patient is sleeping, and theoretically reproduces what occurs when the patient is sleeping at home. So I'm going to give some video examples of what may occur, what you may see during a drug-induced sleep endoscopy. So I'd like to start with a relatively normal exam. And in this particular patient, what we're going to see is some narrowing of the retropalatal area, followed by some good snoring. And then, but as we advance the scope, we're going to see that the hypopharynx stays relatively open. The posterior pharyngeal wall. Here's the soft palate. As you can see, here's the uvula, and it is just getting bounced around pretty good. But if we advance our scope down further, so here we see our larynx, the epiglottis, the tongue base here, but not a lot of tongue base prolapse. Overall, the airway is open. So, by contrast, in this next example, very important. So in this particular patient, she didn't require supplemental oxygen, but sometimes we'll, I think I've seen surgeons place like the nasal cannula in the mouth, or kind of one in the nostril that you're not in, kind of out. We definitely warn ask the anesthesiologist not to perform jaw thrust, to keep their hands off the patient if possible, because obviously they're even doing this, that will affect the way the airway is going to work. So we kind of just try to tell everybody to keep their hands off the patient unless there's an issue that needs to be addressed. So in this example, and I apologize for the graininess of the video, we're going to see a little bit more tongue base collapse. Example, we're basically going to see collapse all over the place. You're going to see some palatal narrowing, lateropharyngeal walls collapse, most impressively, the epiglottis is collapsing in on itself. Palate starting to move in. This patient still has his tonsils, and you can see they make up some space, and they're starting to move inward. Pretty impressive exam. So what really prompted me to pick this subject for this talk were actually these three questions. So is drug-induced sleep the same as natural sleep? What is the reliability and repeatability of drug-induced sleep endoscopy? And what is the evidence out there supporting drug-induced sleep endoscopy as a diagnostic or prognostic preoperative tool? So the first question, is given in a drug-induced sleep endoscopy are of the hypnotic class, and those drugs, their main function is to induce sleep, but they do have a dose-dependent effect that can range anywhere from anxiolysis to unconsciousness. And the most popular drugs tend to be benzodiazepines and propofol, although it seems in the adult population at least, propofol is more popular currently, mainly because it's shorter acting than benzos, causes less respiratory depression, and lower incidence of other side effects such as nausea and headache afterwards. So this particular study compared midazolam-induced sleep with natural sleep by looking at polysomnograms under each state. And it was only a 3-hour PSG while under midazolam. And what these investigators found was the AHI was relatively the same, non-REM sleep was the same, but there was a decreased amount of REM sleep with midazolam. But these investigators concluded that a sleep breathing disorder could be mimicked by sedation. And then a similar study was performed using propofol, and the results were very similar to the previous exam. So they found that with propofol, there is a decrease in stage 1, increase in stage 3, but really no REM sleep was seen. And they did not find that the AHI was significantly altered by propofol, and they felt that this drug was safe, did not cause an increase in obstructive events. But most importantly, they did conclude at the end that it does not replicate natural sleep. So the significance of not being able to simulate REM sleep can be kind of demonstrated in this video. I want to recognize Dr. Shitaro Shiba, who is a Japanese otolaryngologist who did this video recording. So he performed a full night sleep endoscopies while patients were sleeping naturally, and then he also had them hooked up to PSG equipment at the same time. And so in this video, what we're going to see is the upper airway here in non-REM sleep compared to REM sleep. So non-REM, you see the epiglottis is moving back and forth a little bit, but the tongue base really isn't that collapsed, non-REM. But as soon as we get to REM, the tongue base falls back and obliterates the vallecula. You can't really even see the epiglottis anymore. Patient wakes up. So, there is a potential for missing obstructions if we cannot observe them. Another issue is how do we ensure that the obstructions that we are seeing during a drug-induced sleep endoscopy are physiologic in nature and not caused by too much drug being given. And it is greatly, I think, dependent on what technique your anesthesiologist is using. So if your anesthesiologist is using bolus or manual injections of a drug, this can lead to fluctuating blood and tissue concentrations of drug. And one study found that snoring and airway obstructions could be induced between 80 to 95% of all manually sedated patients. And so the correct level of sedation is crucial to produce the right amount of muscle relaxation, but not so great to cause respiratory depression and obstructions. So one proposed way to better control drug levels is using a target-controlled infusion pump. This has a computer that provides instantaneous calculations of the infusion rates to obtain and maintain a given therapeutic drug blood concentration level, and more reliably adjusts the depth of anesthesia, and then allows for better control of the sedative brain concentration rather than blood concentration. And so this device was validated in this study by Barry. He had 2 groups of patients. Excuse me. Well, one group had a history of snoring and apnea. The second group were essentially healthy, normal controls. And they found that no asymptomatic subjects snored during sedation under the TCI, and then snoring occurred in all patients in the snoring apnea group. So they concluded that propofol does not induce sleep identify sites of obstruction and degree of obstruction. And then they calculated kappa values. So a score of 0 means there's no reliability, no correlation. 1 being the raters had perfect reliability with each other. So they found that the kappa value was 0.76 when they were asked to identify sites of obstruction, and 0.6 when it came to the degree of obstruction. So they felt that it was moderate reliability. So most importantly, what is the evidence that supports drug-induced sleep endoscopy as a diagnostic or prognostic preoperative tool? I looked at this in sort of 2 parts. So the first part, if we do this examination, are we actually going to change our surgical recommendations? Well, several studies found that there is a statistically significant non-correlation between what the surgeon sees on an awake physical exam in the clinic and what they see on sleep endoscopy. So in this study, 250 subjects underwent a normal clinic exam, and the surgeon then drew some conclusions about where he thought the sites of obstruction were. And then the same subjects then underwent a drug-induced sleep endoscopy, and the surgeon noted sites of obstruction on that exam. And what he found was that 76% of these patients had a different examination while under drug-induced sleep endoscopy versus their awake clinic exam. And he found that the majority of dissonance was in regards to the tongue base area. The findings of that study are sort of echoed in this other study where surgeons gave a surgical treatment recommendation based on both the physical examination in the clinic and then under a drug-induced sleep endoscopy. And they found that 64% of patients got a different treatment recommendation after their drug-induced sleep endoscopy. And interestingly, the obstructions kind of went both ways. So they noted that clinic exam missed some obstructive sites seen on drug-induced endoscopy, but there's also some sites seen on clinical exam that they didn't see on drug-induced sleep endoscopy. Well, so the problem is they didn't, I have to look at the study, but I think it depends on sort of what type of exam they were doing. Are they doing a Mueller Maneuver, and then so if the patient is inhaling hard and they see some more lateral wall collapse or tongue that when you put them under a drug sedation, it just didn't occur. And so finally, what is the impact on surgical success? So I was really only able to find 3 studies that looked at the impact of drug-induced sleep endoscopy on surgical success rate. This one's in Chinese, and I couldn't read it, sorry, so I'm a bad Chinese person. I should have asked T to come and read it for me. So, and this one's in Japanese, so I don't read Japanese. So I could only look at their abstract, so there's not a lot of information about how they're measuring the success. So I'd definitely take it with a grain of salt. And this is really the only paper that I could find in English. Showed about a 62% success rate, and they define their success rate as an AHI less than 20. And so, obviously, like I said, with a grain of salt, when you compare this to the historical control of Scher's paper, it seems a little better. So it may be suggestive that a drug-induced sleep endoscopy can help predict which patients will have a higher rate of surgical success. But I think certainly it's not conclusive evidence yet. So briefly, just some limitations about this exam. So at most centers, it requires an operating room time and expense. It only captures a short duration of sleep, so you're not doing a full night's sleep. You're usually capturing only 10 to 15, maybe 20 minutes of sleep. It's a lumen-only view, so you only see what's within the airway tube. Ultimately, it is a somewhat subjective and sort of breathing during drug-induced sleep endoscopy seems comparable to natural sleep. And there are some subtle hints that it may change the indication for certain operations. So finally, I'm going to end by talking about sleep MRI. So, sleep MRI is a real-time imaging procedure that makes a movie of the airway in the mid-sagittal plane during sleep. It allows you to look at the palate, the tongue, and the hypopharyngeal region. So the pros are it provides a three-dimensional view of the upper airway. And you can also visualize the soft tissue structures that surround the upper airway. So you can see what's going on in the tube, and you can see what the soft tissues surrounding that tube are doing. Are they pushing up on the tube? Is it full of fat? It's a dynamic exam, and it can be used to identify sites of obstruction and identify patterns of dynamic collapse. So this sleep MRI is courtesy of Dr. Capasso. So first frame is the mid-sagittal plane. In this patient, you can see the palate does a fair amount of collapsing. It seems like the tongue doesn't really collapse all that much. Yeah, kind of a small head, a little Homer Simpson-esque here. That's the problem, too much beer and donuts. And then they also look at axial views too, at the level of the palate and the tongue base. So the literature to date appears to be mainly descriptive in nature. So, for example, in this one paper, they looked at healthy patients, and they found that there was very little dynamic movement of the upper airway during sleep in healthy normals. But when they looked at patients with sleep apnea, they noted these patients had narrow airways even when they were awake and supine. But as soon as they fell asleep, they had a lot of upper airway motion, and this motion included both airway distension and collapse. So a lot of instability. This paper sort of characterized the different patterns of collapse. So if you look at A and B are the same patient. Here is the soft palate, there's the tongue, posterior pharyngeal wall, there's the airway. You can see later on there's a collapse of the palate, but the tongue base stays forward. So really more of a palatal collapse. And in a different patient, C and D here, you see both the palate and the tongue base fall back against the posterior pharyngeal wall. And if you look into an axial view, you can see sort of definitely all kinds of patterns. So A and B, same patient, you see more of an anterior posterior collapse. This patient, C and D, you can see that more of a transverse collapse where the lateral walls come in. And here, B and F, this patient has more of a circumferential collapse that collapse in all directions. So Dr. Jose Barrera, who was a previous sleep fellow here, he looked at the reliability of sleep MRI. That's right, sorry.
But it's prime directed for sleep.
I'm just kidding.
So he looked at the reliability of sleep MRI. And so he looked at both the intrarater and interrater reliability. So just as a reminder, 0 being there's no reliability, and 1 being perfect reliability. And he found that there seemed to be very good reliability in both of these classes. Yes, I did. articles that I reviewed, I did not find any literature that demonstrates the detection of sites of obstruction via a sleep MRI had any impact on patient selection or surgical outcomes. So it's still an investigational diagnostic tool at this point. And in fact, here at Stanford, there is an investigation ongoing currently with Dr. Foster. So in this investigation, just briefly, they actually have the patient fall asleep naturally, so no drug induced, in the MRI machine. They're using a 3 Tesla MRI, so a little better soft tissue quality images will be obtained. And then as soon as the patient falls asleep, they obtain these MRI images, and the patient is also wearing full PSG data at the same time that's MRI compatible. So we'll be waiting excitedly for the results of that. So, some conclusions. Sleep MRI has certainly helped our understanding of the differences in the airway anatomy between patients with sleep apnea and healthy subjects. It's still an investigational tool at most centers, and there's no evidence yet that sleep MRI will impact our surgical outcomes. But I think it's a little too early to say for sure. So overall, the role of drug-induced sleep endoscopy and sleep MRI, I think it still remains to be defined. It certainly can be used to evaluate surgical failures in order to identify residual sites of obstruction, or used in complex cases where the history that the patient is giving you and you're looking at their PSG data, it doesn't seem to match their symptoms or their physical exam. I think it's really important to keep in mind that there is no such thing as the perfect diagnostic tool, and all these tools really should be used to help inform our clinical and surgical decision making in order to better counsel the patients. I'd like to end by thanking Dr. Good, Dr. Paso, and Dr. Chiva. These are some of the references that wouldn't fit on the slides. Thank you. Very valid point. When you're artificially introducing something that may disrupt sleep, as you said, prop tissues forward. They actually, some of these papers have looked at that, saying you're putting the scope in. Are we changing sort of these obstructive patterns? And overall, they felt that based on sort of PSG data and things like that, that it actually did not significantly interfere with those types of I think, with this exam, you can't see the entire airway at one time. So you kind of have to start at one spot, look at the palate, and then kind of go past the palate, see what's happening, but you can't see what's going on above you.
Seems like all done in the pelvic position.
It is somewhat cumbersome, labor-intensive a little bit. I think part of the reason why, at least in my mind, that I wouldn't make such a big effort for that is that obstruction is typically worse, obviously, in supine position, so you're going to capture them in their worst state. I mean, I think there are a few, very, very few percentage of patients who actually are worse when they're in a different position other than their back. So, very rare. So you do. So a lot of the sleep medicine doctors will try to encourage that. They're not great ones. There's the tennis ball in the back, and things like that, or a pillow to try to prop you in one direction or the other. I think a lot of it depends on when you're looking at the PSG and you're looking at what they're doing
so you can suggest positional therapy, sometimes positional therapy alone.
That's a great question. I probably will not use it as much as I thought I did before I started when I did this after doing this literature search. I definitely think it has, as I said, that use in the complex cases or surgical failure cases. But as a routine examination, that would be something I would offer to most of my adult patients. Probably not.
Kid with no tonsils, all that. Like I just described, no tonsils.
Make any comments on your experience with DEX? Say the name of the drug. DEX. Yeah, this one. That kid, 16 years old. That one, by the way, that had the
16?
That's the thing. She's a 16-year-old kid with. Still didn't do anything. We did her yesterday. I still need to. Don't want to do that.
Pillar gun.
Yeah.
The one with the curl that we got at Stanford.
No, that was the guy. That guy actually he had a tonsillectomy. By his tonsils, and then later we did lingual tonsils, and then we repeated, and then his bodies was so still cold, so he's doing oral appliance now. He actually does really well with jaw trust.